In this lecture, we need to understand about hemostasis. We have to cover the clotting cascade and responses to injury. The process of hemostasis refers to the need to restrict blood flow locally as a result of injury. So for example, if you injure your arm, that's the site of injury, and you'll injure small blood vessels such as arterioles, capillaries and probably venules. In order to prevent a major hemorrhage, you need to restrict the blood flow to that area. Please note the process is hemostasis, not homeostasis. So this is a situation where you have to be careful with your spelling. The process is mediated by a complex network of hormones and other factors and occurs in a cascade response. So you start off small and end up with a massively amplified reaction. At the same time as this occurring, inflammatory response is being initiated by other factors which are also involved in the coagulation process. To take an example, if you have an injury to an epithelial cell wall, for example, you've cut your arm, this will expose the collagen. This is shown in the first of these three diagrams at the bottom, where you can see the smooth muscle cell of your blood vessels. Collagen and extracellular matrix proteins have been exposed, damaged the basement membrane and damaged the epithelial cells. At this point, the platelets start to aggregate at the exposed site at the same time as vasoconstriction is occurring to reduce the amount of blood flow. Tissue factor is released from the damaged tissues, and that directly activates the coagulation cascade. Other cells, such as neutrophils, are involved in maintaining the safety of the body by acting for the immune system. Platelet aggregation occurs. At that point they become activated. There are a variety of components involved in the coagulation cascade, which we'll come on to shortly. The ultimate end of this is to produce something we call a hemostatic plug. At this point, it's the primary beginnings of a blood clot. When you actually injure yourself and the blood clotting cascade begins, a von Willebrand factor is what actually causes the platelets to adhere to the substrate at the site of injury. Those activated platelets start to become very, very sticky and form a temporary hemostatic plug. While they're doing that, they also start to synthesize and secrete various mediators. For example, ADP, which starts to cause the cells to sickle. Please note this is not the same as sickle cell anemia or sickle cell trait. The other key factors that you must know about being produced are thromboxane, A2, 5-HT, serotonin, which causes the vasoconstriction, thrombin, which is a key modulator in the clotting cascade, plus various other clotting factors. Phospholipids and lipoproteins are also produced. However, it's important to note that clot formation is inhibited by nitric oxide and PGI2. The damaged tissues, so the collagen's been exposed and the damaged tissue releases something called tissue factor. When we come to look at the blood clotting cascade, you'll see that lots of factors have different names associated with a factor number. This relates to the order in which they are identified. So for tissue factor, it's also known as factor 3. The platelets form the platelet plug, and a prothrombinase complex is involved in cleaving prothrombin to produce the mediator of thrombin. Thrombin itself then cleaves fibrinogen to create fibrin, and the clot forms by bonding to fibres of fibrin. If you look at this diagram, it's available in your Tortora textbooks if you wish to look at it. You can see red blood cells trapped within fibrin threads. From this slide we need to cover the clotting cascade and what is actually happening. As you can see from this slide, there are three key points that I need you to know. So I need you to understand that the intrinsic pathway is activated by damaged surfaces and results in the production of kininogen and kallikrein. The extrinsic pathway is activated by tissue trauma and results in the release of tissue factor. You don't need to know the bit in the middle that does not have a red circle around it, but you must be aware that this is a comprehensive cascade. The final part I need you to know is the final common pathway. At this case, both the intrinsic and extrinsic pathways ultimately activate factor 10 to create factor 10A. By the time you get down factor 10A involving factor 5A, this brings you to the final common pathway. You must know this final pathway. The final crucial stages of the clotting cascade is that prothrombin, or factor 2, is converted into thrombin, factor 2A. Fibrinogen, factor 1, is converted to fibrin, factor 1A, by the action of thrombin. Fibrin then results in the cross-linked fibrin clot, which we know as a scab or a blood clot. Make sure you understand how these two pathways link into the final common pathway. Throughout the clotting cascade, there are a variety of coagulation clotting factors that we find, and there's also a variety of complexes that we find. I need you to know the details on all the following slides. Clotting factors are proenzymes, so they're converted into an enzyme only when activated by another enzyme. Proenzymes are also sometimes termed zymogens. To give you some examples, factor 2, prothrombin, factor 7, factor 9 and factor 10 all contain vitamin K dependent carboxyglutamate residues. Calcium and platelet phospholipids bind to these residues and convert these factors into active serine proteases. The complexes I need you to know about are on this slide. So the first we have the tenase complex, which is composed of factor 4. Factor 4 is actually calcium ions, factor 8A and factor 9A. Together this complex activates factor 10. Factor 10 is produced by the liver and, as I've said on the previous slide, is a vitamin K dependent entity. The second is prothrombinase complex, which is involved in cleaving prothrombin to produce thrombin itself. This complex consists of factor 4 again, so calcium, factor 5A and factor 10A. Both of these enzyme complexes bind phosphatidylserine and phosphatidylinositol on the platelet surfaces. Factor 5A and 8A are both proenzymes and act as cofactors here, and are activated by a decrease in the concentration of thrombin in the plasma. However, they are also cleaved in the presence of an increased concentration of thrombin in the plasma. The key message you must take from this slide is that thrombin itself regulates the extent of blood clotting. In addition to understanding the factors that stimulate and activate the coagulation cascade, you need to understand about how this pathway is inhibited. One of the main problems of the coagulation cascade is how efficient and effective it is. If it's left unchecked, significant amounts of the blood would continue to form a clot, and that will cause major problems for the patient. The three listed on here are all inhibitors of coagulation, and I need you to know all of them. So the first is tissue factor pathway inhibitor. This is a plasma protein which binds to tissue factor and factor 7A complex. The second is thrombomodulin. This is an endothelial surface receptor protein that's found on the endothelial cells of the blood vessels, and it binds thrombin. Together this complex activates protein C, which then complexes with protein S and inactivates factors 5A and 8A, which, if you remember from the last slide, are cofactors. The third is antithrombin 3. Similarly to tissue factor pathway inhibitor, this is a plasma protein. In this case, it binds to heparin on the endothelial cell surface and inactivates thrombin and factor 10A. In summary on clot formation and clot degradation, if you have a look on the left-hand side first, you see the extrinsic and the intrinsic pathways, very briefly explained. Note that calcium is essential at various places in this cascade. It's actually involved in far more places in the cascade than shown here. All I need you to be aware of is that calcium is an essential factor involved in clot formation. At the bottom you'll see the common pathway of prothrombin being cleaved to thrombin, which then cleaves fibrinogen to fibrin. At that point we move over into the fibrinolytic pathway of clot degradation. So fibrin then is broken down and we start to see fibrin degradation products. The presence of fibrin and the products of degradation activates tissue plasminogen activator, which then goes through and activates various other parts of this cascade, which then go down to further break down fibrin to produce those fibrin degradation products. There is a balance between clot formation and clot degradation, which, when kept in check, means that our blood does not spontaneously clot, will only clot in relation to any activation of the extrinsic and intrinsic pathways, and then clots are rapidly removed as soon as they're no longer required. If there's something goes wrong and you end up clotting in an intact vessel, this state is a thrombosis. It can be activated by an atheroma. Atheroma is where you have a plaque deposited on the inside of a blood vessel. This can damage or distort the endothelium. By damaging the endothelium, you effectively activate the clotting cascade. It can also result from hypercoagulability, so an increased tendency to clot anyway, or a bacterial infection, which again can lead to damage to the endothelial lining. Ultimately, a thrombosis will lead to an embolism, which is a blockage of a vessel. If that happens in the heart, this is a coronary thrombosis or a myocardial infarction. In other words, it can lead to a heart attack. If it happens in blood vessels in the brain, it can lead to a stroke. If it happens in the lungs, that's termed a pulmonary embolism. The one that most people will have heard of is deep vein thrombosis. This is when a blood clot has developed spontaneously within the deep veins, usually of the legs. You've probably all heard the terms economy class syndrome. This is where people who have been travelling, for example, on an aeroplane with limited leg room, don't move around as much. As a result of that sedentary position, the blood isn't flowing through the veins as usual. You need to move. The action of walking, the muscles actually pump the blood vessels, so they help move blood through the venous circulation. If you remember from the last lecture when we discussed blood vessel structure, I mentioned that veins and venules have vessels going through them, and they actually have valves along the length. It's those valves that prevent the blood from just backflowing and pooling in the feet. However, if you're inactive, for example, on an aeroplane or on a long car journey, you do not have the same muscle contractions that you get when you're walking that will aid the blood moving up through the veins. As a result, the blood stays more stationary in the veins and leads to a greater likelihood of developing a spontaneous deep vein thrombosis. The treatments for thrombosis largely depend on what's happening with the patient and where the clot is formed. For example, you would treat a patient suffering an acute myocardial infarction differently to a patient who is identified with a small blood clot in the leg which is not yet occluding the blood vessel. Antiplatelet drugs are extremely useful in these situations. And a good example is aspirin. Aspirin inhibits thromboxane A2 formation by the platelets. This prevents the platelets from becoming sticky, adhering together and forming the primary hemostatic plug. You may have heard of aspirin being given prophylactically to patients who are at high risk, for example, of stroke or heart attack. If a thrombosis has already formed, then you need to consider giving your patient an anticoagulant. These inhibit the coagulation cascade, so while not directly removing the blood clot, it prevents that clot from getting any bigger, allowing your body's own fibrinolytic system to kick in and dissolve the clot naturally. The two we have in use usually are heparin, which is administered as an injection, or vitamin K antagonists such as warfarin, which is administered as a tablet. If you're on anticoagulants, then you need to have your patient measure something called their blood international normalization ratio, or INR. The INR gives us a measure of how much that blood is able to clot. Under normal circumstances, you have a set value. When you have a patient on anticoagulants, you need their blood INR to change to indicate that they are not only at a lower risk now of clotting again, but also to ensure that your patient doesn't start to hemorrhage. As a result of these preventing the clotting cascade, any bleeding will be more severe in patients who are on anticoagulants than who aren't. Bruising is very common in these patients as they bump themselves on everyday objects and they bleed under the skin more than you would usually. Finally, the final arm, if you like, in treatments for thrombosis are the thrombolytic agents, affectionately known as clot busters. Things like recombinant tissue plasminogen activator and streptokinase are used here. These are agents which do directly dissolve the blood clot itself. These would be far more used, for example, if you have a patient where a blood vessel is completely occluded. There are several other disorders of haemostasis. The three listed here, again, I need you to know about. So first of all, von Willebrand's disease. This is a gene-linked deficiency of von Willebrand factor, and in these patients we see abnormal levels of bruising and severe mucosal bleeding, so bleeding of the gums, for example. You'll probably all have heard of haemophilia. Haemophilia, again, it's a gene-linked deficiency. In this case, it can be of two different factors. If it's a deficiency of factor 8, it's termed haemophilia type A, or factor 9, which is haemophilia type B. Haemophilia, as you know, means you get excessive bleeding. It can be tough tissue bleeding and bleeding into the joints. So again, causing disability, considerable pain. Significant risk of a patient hemorrhaging, therefore you need usually put in some form of replacement factor to ensure that these patients clot more normally. I mentioned earlier that some of the factors, for example factor 10, is produced by the liver. Liver disease is a major cause to have problems with haemostasis, as you end up with a deficiency of coagulation factors. This can also be due to a reduced absorption of vitamin K. In this case, we teach with the procoagulants. By treating with procoagulants such as vitamin K or desmopressin, we can replace those factors that are missing by the liver disease and help to reduce the risk of bleeding in the patients. So that's all we're going to cover on the blood clotting cascade itself. If you have any questions on that, please contact me. Alternatively, this subject is covered extensively in your textbooks. We're now going to move on to inflammation, which is the process that occurs in response to tissue injury or infection. Inflammation is a key part of the immune response and is actually essential. We tend to think of inflammation as always being a bad thing, so inflammatory disease, for example. However, it's crucial to assist us in fighting infection and to stimulate repair of tissue damage. There are various mediators involved in the inflammatory response. For example, some are derived from cells, such as the prostaglandins, leukotrienes, histamine, platelet activating factor. ADP itself is a mediator for inflammation, as is serotonin. You will probably have heard of serotonin as being used as a neurotransmitter. It's involved in the periphery as well. There are plasma-derived mediators involved here, such as bradykinin and the complement factors, but there are also mediating neurotransmitters. Substance P actually stands for powder, not pain, but is involved with pain perception, and something called calcitonin gene-related peptide, or CGRP. We're going to take a step back initially, and we're going to go over some basic metabolism, in this case of arachidonic acid. So first of all, if you look at the very top of this diagram, you'll see there's mitogens, cytokines, and other stimuli which are acting through a MAP kinase pathway. At this point, we get using phospholipids, lipases, especially CPLA2, converts phospholipid arachidonate into free arachidonate. There are other esterified arachidonates which are converted to the free form by the action of the esterase enzymes. Through a particularly complex series of events that I don't need you to worry about, free arachidonate is converted to prostaglandin G2 and then prostaglandin H2 via the cyclooxygenase complex. At this point, there are 5 potential routes that this complex can go through. So thromboxane synthasase will convert this to thromboxane A2. Thromboxane A2 can actually be further changed to thromboxane B2. Reductase enzymes will convert our PGH2 to prostaglandin F2 alpha. Isomerase will convert it to prostaglandin E2 or prostaglandin D2. And finally, prostacyclin synthase will present this to prostaglandin I2, which can further be converted to 6-keto-prostaglandin F1A. All of these products will eventually come through to produce urinary metabolites via reductase, dehydrogenase enzymes, and beta oxidation. These metabolites all then removed in the urinary system, which we'll come on to later. But arachidonic acid is exceptionally important for the production of a vast number of our inflammatory immune mediators. If you have some form of tissue injury, it can be trauma, for example stepping on a nail, or an immune hypersensitivity reaction, in other words, an allergy. Ultimately, you end up with damage to the vasculature, which leads to contact of the blood with the subendothelial and extravascular tissues. So these are tissues that should not normally come into contact with blood itself. The damaged tissues and activated platelets then go on to release ADP, serotonin, thromboxane A2. Damaged cells themselves start to yield prostaglandins. Plasma kallikrein, which was involved earlier in the clotting cascade, is further cleaved to form bradykinin. At the same time that this is occurring, the sensory nerve endings release substance P and CGRP to send the message up the afferent nerves to your brain to indicate that there has been some form of tissue injury. Pain is how your brain determines that there has been damage there. It serves the purpose to protect whatever damaged area is. So for example, if you sprain your ankle, you'll be very reluctant to put your foot down and weight bear because of the pain. That's your brain realising that putting weight through a damaged tissue will cause further damage. Neuropeptides further stimulate degranulation of the mast cells. Mast cell granules contain histamine amongst other things. So histamine is a vasodilator, prostaglandins and leukotriene D4. Prostaglandins and the leukotrienes are leukocyte chemoattractants. So at this point, your blood vessels are dilating under the efforts of histamine, so you're getting an increased blood flow through your body, or at least to the area that's damaged. Meanwhile, these prostaglandins and leukotrienes are attracting the white blood cells to that area of either damage or hypersensitivity. Meanwhile, the complement system is activated. Complement is a process of serum proteins that form a massive cascade. They're part of the innate immune system, so they're not specific for any given infection. However, they're extremely effective in inflammation. The key two molecules you need to know from the complement system is complement factors C3a and C5a. Both are leukocyte chemoattractants. The 4 stages of inflammation are listed here. So rubor is redness. This is a result of the vasodilation, so an increased local blood flow. This is due to histamine and the prostaglandins. If you imagine for a moment that you've scratched your hand down, say, a rusty nail, you know that the first thing that happens is that the line goes red, it gets very hot, and it starts to swell up. The heat is called calla. Again, this is due to vasodilation. You've got more blood closer to the surface of the skin, so you're having more heat radiating out of that blood. You also have stimulation of the sensory nerves. So the prostaglandins, 5-HT, serotonin, and bradykinin also stimulate these sensory nerves, and that is perceived as heat response. Swelling is called tumour, and again increased vascular permeability here due to CGRP, leukotrienes, bradykinin and histamine means that there's increased amount of fluid is being forced out of your blood vessels and into the surrounding tissue. The final aspect of inflammation is called dolor or pain. Again, stimulation of the sensory nerves, prostaglandins, serotonin and bradykinin, and this is translated by the brain as being pain. The end result of inflammation is tissue repair. The increased blood flow, increased vascular permeability and the chemoattractants all recruit leukocytes. That means that if there is any infection there, any bacteria or other foreign bodies, they will be removed, infection will be cleared and allow the best possible conditions for the tissue to repair itself. While all this is occurring, you start to see a proliferation of certain cells, specifically the fibroblasts, which produce the extracellular matrix. If you have a severe enough injury, for example a surgical injury or a severe cut, you find that you end up with a scar. The scar has a different appearance to normal skin. The scar is the fibroblasts and the extracellular matrix forming this tissue to basically fill the gap that the injury has left. Scar tissue is not as flexible as normal tissue, and it doesn't have any nerve endings, so you can't actually feel anything through the scar tissue. It also lacks sweat glands and hair follicles. As a result, if you have extensive scarring across your body, you may start to struggle with maintaining your body temperature. finally, you have proliferation of muscle and epithelial cells to close the wound. Over time, scars will fade. Deeper scars won't, but superficial scars will. In summary then, haemostasis requires clot formation to repair our damaged vasculature and prevent excessive bleeding. The clotting cascade requires a complex system of enzymes, cofactors and clotting factors to maintain this safely. It's strictly regulated as a cascade. The two key things I need you to remember from the clotting cascade are the fact that vitamin K and calcium are essential, and you must remember the final common pathway. Finally, inflammation is linked to the clotting cascade through common mediators, especially thrombin, which is an activator for both pathways. I understand that there's a lot of detail in this lecture. If you need any additional help, again, as always, please don't hesitate to contact me.